Good morning, everyone, at least here in Boston, where it's 9 a.m. Thank you so much for this opportunity to present with CyberSight. It's my first time doing it, and I'm very excited. And today, I'll be talking about basically cyclodestructive procedures, specifically transscleral and endoscopic cyclophotocoagulation. I'll try to share some good stories, some challenging stories, and share some lessons learned along the way. And I'm Dr. Sola-Del Valle. I usually go by Dr. Sola. My patients know me as that. I'm an assistant professor at Harvard Medical School, and I'm a glaucoma specialist at Mass Eye. My only financial disclosure is I used to be a speaker for the Zangel stent in 2021, but this should not be relevant for the talk. Just a little bit about myself so you know who'll be with you for the next hour. A little bit of a personal history. I was born in Germany in an American military base, but I was raised in Puerto Rico. So Spanish is my first language. And I've actually given a few of these talks in Spanish, which has been a lot of fun. Then I moved to Cambridge / Boston in 2000, and I went to Harvard undergrad. And I actually majored in biochemistry. I also did a little bit of Italian. That was my minor. And that actually led me to spend a year in Milan. I did a little bit of research at the European Institute of Oncology before coming back to the US, finishing medical school in New York at Columbia, then moved back to Boston and did my internship at Mass General, which was a great experience, and then started my residency in ophthalmology here at Mass Eye, where I currently work. I did go down to Miami at Bascom Palmer and had a great year there where I did my glaucoma fellowship. And then I came back up to Massachusetts and did a stint in private practice. I worked in private practice for a year, and that was a great experience, grew a lot as a surgeon and clinician. But ultimately, academic medicine called my name, and I started here as a glaucoma specialist at Mass Eye. And I've been here since 2017. And here at Mass Eye, I'm a very busy clinician and surgeon, although I also run a lab that focuses mostly on clinical research and translational research. Today, in this webinar, I want to focus it on three basically types of cyclodestructive procedures, which are the ones I most commonly use or combinations thereof. I want to talk about the continuous wave transscleral cyclophotocoagulation, or for short, many times I'll refer to it as the gprobe during the talk. Then I'll talk a little bit about Micropulse or Micropulse transscleral cyclophotocoagulation. And again, I'll just probably refer to it throughout the talk as Micropulse. And then I'll also chat a little bit about the endoscopic cyclophotocoagulation, or ECP for short. I have a poll question for each one. I'll try to introduce each one. I'll talk a little bit about settings for the transscleral CPC. I tried to put as many videos as I could. I always find that videos are a good way to learn and talk about how exactly I do all these procedures. I'll try to share some data about each procedure. I mean, I aim to practice evidence-based medicine, so I try to include some data to kind of justify why I do the things I do. I'll talk about some pros and cons, and when it comes to Micropulse and ECP, and even gprobe, I'll try to share some patient cases, and again, successes and failures or challenges that I've had throughout the years. So again, this talk talks about cyclodestructive procedures. I think we all know this is a very important treatment choice. It has been since the 1930s. That said, the procedures have been refined a lot throughout the years. And ultimately, cyclophotocoagulation started to be used in around 1970s, 1972, first with the Ruby laser, then the ND-YAG and diode laser. The basic aim of these procedures is to reduce aqueous humor production. And recently I was at Bascom giving a talk, and Dr. Richard Lee, who's a big fan of CPC, he said CPC and ECP, these are the ultimate mix plus procedures because they're really minimally invasive, especially transscleral CPC, where you don't have to make an incision in the eye. I do want to put in a plug for a review article that my team in the clinical research lab I run put together. We published it in 2020. It's a review of cyclodestructive procedures in the treatment of glaucoma, and it summarizes essentially these three types of cyclodestructive procedures I'll be discussing today. And a lot of the tables I show today come from that review article. This is the first poll question, and it's basically, which of the following is false regarding continuous wave transscleral cyclophotocoagulation? They're a little wordy, I apologize. It was hard to come up with poll questions that were very, very accurate and short at the same time. The first, continuous wave laser energy is delivered to the ciliary body via a laser probe placed approximately 1.2 millimeters from the corneoscleral limbus. B, the original recommended settings for the semiconductor diode ranges from 1.25 to 1.5 watts for 4 to 4.5 seconds. C, it utilizes repetitive pulses of energy separated by periods of rest, which allows for more targeted treatment of the pigmented tissue in the ciliary processes. Or D, energy is applied in distinct locations with care to avoid treating the 3 and 9 o'clock positions to minimize the risk of damage to the long posterior vessels and nerves. Yeah, and 47% of you picked the right answer, which is continuous wave by definition means that the energy is delivered in a continuous fashion, not in repetitive pulses. That's actually one of the distinguishing factor, honestly, between continuous wave transscleral cyclophotocoagulation and micropulse, which we'll be talking about today. A little bit about transscleral cyclophotocoagulation in general. I would say the two most common variants are the continuous wave and the micropulse. The laser energy is administered through the sclera. And again, that's one of the great benefits of this procedure. You don't have to make an incision in the eye, and it's absorbed by the melanin in the ciliary processes. And, I think CPC or TSCPC in general sometimes has a bad rep because, especially earlier in the day, the cyclodestruction procedures were associated with very severe complications like prolonged uveitis, damage to corneal nerves, eye pain, ptysis, among others. Not to say that this doesn't happen anymore, but I think a lot of these complication rates have gone down significantly, and that's something to keep in mind. Now, a little bit about the continuous wave CPC. Again, the gprobe or the continuous wave TSCPC, it delivers energy in a continuous wave. We have basically two probes. I usually use the gprobe without illumination, but there is a gprobe Illuminate available that technically helps you see a little bit the ciliary processes when you're lasering. I find that the gprobe is particularly helpful in refractory glaucoma. In general, CPC is very helpful in refractory glaucoma. And I think the main thing to keep in mind with continuous wave TSCPC is that although it's very effective in lowering IOP, there can be a significant risk of complications depending on the power used and the eye that's being lasered. And I think decrease in visual acuity is one of the main ones that we worry about, hypotony we worry about, and chronic uveitis and ptysis. Although again, the rates have decreased over time. In terms of the settings, the gastrolens settings, I remember when I was a fellow at Bascom, Dr. Parrish always talked about the gastrolens settings. I think these are the original settings that Gastrolin developed when he was treating rabbits. They go anywhere from 1.25 to 2.5 watts for between 2 and 4.5 seconds. And I think the key thing that distinguishes these settings is that we try to titrate the energy until we hear an audible pop. I think a lot of people, a lot of surgeons are trying to steer away from trying to hear a pop because when you're hearing a pop, you're basically hearing a destruction of the ciliary process, pigment gets released and there's inflammation. And a lot of people have switched to what we call slow burn settings, where you use lower power, essentially 1.25 watts or 1200 milliwatts, but then you leave a pretty long duration of 4 seconds. And the aim here is to not hear a pop, essentially. I would say a lot of us in glaucoma try to basically straddle between the two. I typically, when I do gprobe by itself, which I have to be honest, I do less and less. I probably did one gprobe case last year, even though I do a lot of CPC, and you'll see how I do it in a second. But usually when I do gprobe, I probably start around 2 watts and I do around 3 seconds. And I still want to hear some pops, but not like strong pops, just like very mild pops when I do gprobe by itself. And this is actually a video that we recorded of us doing gprobe on a patient. And this is actually one of our residents, Dr. Bao, who's fantastic, teaching one of our medical students, actually. Obviously, I was there, also helping them out. But I think this is actually one of the benefits of transscleral cyclophotocoagulation, that it's actually relatively easy to teach compared to a lot of our ophthalmic surgeries, especially when you're in an academic center trying to teach trainees. And essentially, this is us putting the, basically the ended. Here we basically are putting the G-probe right at the limbus. We're trying to tell the medical student to put pressure down and basically keep the pedal down the whole way. I usually, when I do G-probe, I do between 18 and 21 spots when I do G-probe by itself. And again, rarely do I do that anymore. And I do try to hear pop, but again, not a huge pop. And as soon as I hear any sort of pop, I kind of turn down the energy. This is actually a table out of the paper that we put together, the review article that we published in 2020, and it basically summarizes all the studies we could find between basically the last 20 years, between 2000 and 2019. And again, these studies are focused only on the G-probe, only on continuous wave transscleral cyclophotocoagulation. And I know there's a lot of numbers here, so I tried to summarize it. Basically, what the studies show that you can decrease intraocular pressure from 7 to 25 millimeters of mercury. So again, huge range, which speaks to one of the limitations of CPC in general, because again, it depends so much on the settings and how you do it and what patient you do it on, but generally very effective. And the same thing when you look at the IOP reduction in terms of percentage, you get percent reduction between 29 and 60%. So again, very effective. And the medication reduction varies also, maybe not as much. I think a lot of the times when we're doing CPC, especially G-probe, we're doing it in eyes that are fairly sick and patients who are on a lot of medication. So many times the aim is not necessarily to decrease medication, but just to lower pressure to try to save an eye. So I think that's reflected here where the mean medication reduction was only 0.2 to 2, although 2 is significant for a lot of patients. In general, continuous wave CPC or G-probe, as I said, one of the biggest pros is that there's no incision, which is why some call this the ultimate MIGS procedure. The other benefit, it's very quick. In the operating room, once the patient is blocked, it only takes about 5 minutes. In general, the recovery is relatively fast in comparison to, say, a trab or a tube. As you saw, it's easy to teach. Even a medical student here at Harvard, we were able to teach her how to do it on her first day. Generally very effective. And there's a lot of settings to choose from. And I list that as a pro and a con. It's great because you can, once you have a lot of experience under your belt and learned what works in your practice and in your patients, you do have options in terms of settings. But it's also a con because it's not one size fits all. And that's something to keep in mind. I think the main con is that compared to Micropulse and ECP, I do think it has a relatively high risk of complications depending on the setting and the eye being treated. The studies that I just showed, that table had a 20 to 64% visual decline. And again, it depends on the patient. It's 1 to 2 lines. And for some patients, that's better than, turning NLP, right? But it is definitely something to keep in mind. And this is actually one of the reasons why when I do G-probe by itself, which again is very rare nowadays, I try to avoid eyes that see well. So I reserve G-probe by itself for eyes that are, kind of an end-stage glaucoma. I'm trying to keep them comfortable. I'm trying to decrease medication burden maybe a little bit. And I'm trying just for the optic nerve not to die instead of, trying to do anything else. One big con of transscleral cyclophotocoagulation in general is that you can't directly visualize what you're doing. I find that even with the gprobe Illuminate, which I've only used a couple of times, I just can't see what I'm treating. And I think that's it's nice to see exactly what you're doing, right? We're ophthalmic surgeons, we're very precise. And I do think this sometimes isn't as precise as I would like. Okay, so this is a second poll question. I'm moving on to talking a little bit about Micropulse now. And this is, which of the following is true regarding Micropulse transscleral cyclophotocoagulation, or MP probe for short? A, repetitive pulses of energy separated by periods of rest, which allows for more targeted treatment of the pigmented tissue and the ciliary processes are used. B, the laser power is adjusted just below the level at which pops are heard, which signify an intraocular uveal microexplosion. C, continuous wave laser energy is delivered to the ciliary body via laser probe placed approximately 1.2 millimeters from the corneoscleral limbus. Or D, it allows for targeted control ablation of the ciliary processes with direct visualization and titration of power. And again, I'll give you, I was told to give you 30 seconds or so to read all the options. And again, which of the following is true? And the last one was false. So this one is true regarding micropulse transscleral cyclophotocoagulation. Great, and again, most of you actually got the right answer here too. I think this, again, this is the distinguishing factor between micropulse transscleral cyclophotocoagulation and continuous wave transscleral cyclophotocoagulation, is that in micropulse, you have these repetitive pulses that allow for periods of rest. The B and C are true of continuous wave transscleral cyclophotocoagulation, or gprobe. And D, the main reason D is wrong is that unfortunately you still don't get direct visualization with micropulse. This is true of ECP, of endoscopic cyclophotocoagulation. So a little bit about the micropulse probe. And I know necessarily the micropulse may not be available everywhere in the world. Even in the US, depending where you go, it's not available. But it is a relatively novel procedure. And again, the benefit is those series of short pulses that get delivered. And the fact that you're allowing for this cooling period to happen with thermal dissipation between bursts, which is what this graph is trying to show. I don't know if you remember the graph I showed for continuous wave, where it was all green all the time. Here with micropulse, again, you're having those periods of rest. And those cooling periods or rest periods theoretically allow for reduction of damage to the surrounding tissues, while, again, theoretically preserving IOP lowering activity. I think one of the maybe confusing things about the micropulse probe is that when it first came out in 2017, 2018, we were using the generation 1 probe, which is showed here up here. And a lot of us kind of got used to using that, and then, but a lot of glaucoma surgeons also complained that the shape of the generation 1 probe was difficult to use. So then in 2019, they decided to change the probe to the generation 2 probe. And for me, this has thrown a little bit of a wrench into the equation, because a lot of the studies I did, and I'll show you a lot of the studies I did, were done with the generation 1 probe. And then you get used to the generation 1 probe, how to use it, how it works, and all of a sudden we have to use the generation 2 probe. The company says that the 2 probes are identical, but anecdotally, I'll tell you that I don't think that's necessarily true. At least the way they work, I don't think are identical. And in fact, it took me a little bit of trial and error to find settings that worked with the generation 1 probe. And the same happened with the generation 2 probe. And I think one of the biggest drawbacks of the generation 2 probe is that we don't have much data out there that's actually looked at the generation 2 probe and its effectiveness. And then my lab team is actually working on collecting the data we have from SNR to see if we can publish some data with the generation 2 probe. And the other thing that's been very controversial with micropulse is, does it work? Is it effective? I found that it's very dependent on the settings that are used. And I've honestly transitioned to using what I call augmented micropulse, and I'll talk about that in a second. And I find that when I do augmented micropulse, it actually works. Whereas if I use the settings that the factory or the company recommends, I find micropulse is much less effective. The one benefit I'll say micropulse has is that it's generally safer than continuous wave transscleral cyclophotocoagulation or gprobe. I find that it's much easier for me to do this procedure, the micropulse procedure, in eyes that see well or in eyes that may not be as sick. And I find that the risk is really much, much lower, even with the augmented settings that I'm about to show you. And again, this is one of the main drawbacks of Micropulse CPC is that the power settings, the ideal settings are controversial. I don't think in the field we all have come together and said, oh, these are the settings everyone should start using and then vary from there, which I think we did that for gprobe, but not so much for Micropulse. So the power settings in the studies that have been done so far vary from like 1.6 to 2.4 watts. I have full disclosure now with the Generation 2 probe, I use 2.7 watts. Maybe because my patients are sicker, they need that extra power, but I find that that's what works for me. The total treatment duration goes from 100 to 300 seconds total, 360 seconds total. And this also gets a little confusing because some people say, oh, I do X number of seconds per quadrant, I do X number of seconds per hemisphere. So it just gets a little bit confusing sometimes when you look at the studies. So I try to, when I'm looking at a study, to look at the total number of seconds that are given. I personally, when I do Micropulse CPC, again, I use the augmented settings, which I'll show you in a second. And that's essentially 180 seconds per hemisphere or 90 seconds per quadrant. That's what I do. There's a lot of variability also in the probe motion. And, you know, when I was down at Bascom in January at that symposium we had, there was another expert in CPC who was, you know, making the argument that really exactly what motion you use while you're doing the sweeping technique makes a big difference. And I believe it. I've just found that it's hard to quantify that, especially if you're working with trainees. But the recommended technique is called the sweeping or painting technique. And I'll show videos in a second of this, where you're just sweeping the probe back and forth slowly. But I have to say that I really like combining the sweeping technique with the stop and continue technique or the discrete spot technique. And I call that, that's what I call augmented Micropulse. And I've had very good success doing it this way. Let me see if I can show you. So first, let me show you the sweeping technique. This is the Generation 2 Micropulse probe. And again, this is one of my trainees, one of our wonderful residents. I use a lot of OcuCode on the eye when I use the Generation 2 probe. With the Generation 1 probe, I actually used to use BSS, balanced salt solution, and I found that for the Generation 1 probe that worked best. But for the Generation 2 probe, I found that OcuCode works best because this probe, it does have the benefit that, you know, it has those bunny, they call them bunny ears that really hug the limbus. Hopefully you can see that here. And you're less worried about it sliding around, which was a concern I had with the Generation 1 probe when we were using that. But anyway, with the sweeping technique, you're literally going back and forth very slowly, and that's about how slowly I like to go back and forth. And I want to say that this is the technique that the manufacturer recommends. But again, I've had success combining the sweeping technique with what I call the stop and continue technique. And here I basically divide the hemisphere into 9 sections, and I stay in each section for 10 seconds. No pops are heard throughout. Again, that's one of the benefits of Micropulse. And even doing it this way, I don't hear pops. And I find that when I do this stop and continue technique with the sweeping technique, I'm a lot more successful in terms of lowering IOP. I do want to say that when I do the stop and continue technique, I like to use a lot of OcuCode because otherwise you do run the risk of having conjunctival burns, which I've found are not the end of the world. You know, you can give some ointment and the patient does well and it's fine, but you know, it's as surgeons, we try not to damage the eye. So, but you won't if you use a lot of OcuCode, if you have a lot of viscoelastic material, essentially, or viscous material on the surface. So that's why I think you saw me in the video there, really trying to use a lot of OcuCode in the eye. And I found that way, it's like nothing happened. You really have no evidence that you did the stop and continue technique. And again, it's dividing the hemisphere into 9 sections. I stay in each section for 10 seconds. For those of you who are familiar with the Micropulse machine, it actually counts down for 90 usually, and use 90 seconds and then 80 seconds. So basically every time I hear, I'll play this again. Every time I hear, so this is, let's say I start at 90, I basically stay in that place until I hear 80. And then when I hear 80, there you go, I move a little bit, okay? And then I stay there for 10 seconds. And again, this is what I call the stop and continue technique, which in combination with the sweeping technique, I'm calling the augmented micropulse. So again, in the augmented micropulse, I tend to do 90 seconds of sweeping in the hemisphere. And then after I'm done sweeping for those 90 seconds very slowly, and again, I'm still here sweeping, so I'm sweeping very slowly using a lot of OccuCode and using that sweeping technique. Again, 90 seconds per hemisphere or 45 seconds per quadrant. Then when the 90 seconds are done, then I switch to the stop and continue technique. And here again, I'm showing the stop and continue technique where I start 90 in one place at 90 seconds. And then every time I hear 80, 70, 60, I switch a little bit and I stay in one place for 10 seconds. So each hemisphere with the augmented technique ends up getting 180 seconds. 90 seconds are sweeping, 90 seconds are stop and continue technique. Now, let me show you some data. Again, this is out of our review article that looked at cyclodestructive procedures. This is looking at Micropulse data. Again, the main drawback of this data is that it uses the generation 1 probe, but it's essentially the data we have because to my knowledge, not a lot of people have published on the generation 2 probe yet, although I know a lot of us are trying to get our data together. But anyway, looking at Micropulse with generation 1 probe, the IOP reductions were from 6 to 17. Again, a little less than what you would get with gprobe. Again, depends a lot on the settings. The reduction 27 to 46%, still decent, although again, maybe not as strong as the gprobe. And then the medication reduction from 0.5 to 1.6, maybe similar, still a little bit less than the gprobe, but again, I find that with the CPC, sometimes medication reduction is maybe not as powerful as IOP reduction. I want to highlight a few articles, and this article basically from the European Journal of Ophthalmology was looking at Micropulse TSCPC using this standard protocol, which is essentially the manufacturer protocol. So the manufacturer only recommends sweeping technique about 40, 50 seconds per quadrant. But even this paper, they did show it worked. I mean, they decreased the IOP from 28 to 18, more or less at 1 year, and they decreased the number of medications by almost 1 at 1 year. Again, a drawback of all these of the studies I'm going to show you now is they all use the generation 1 probe. So I think the jury's still out on how the generation 2 probe compares and studies the generation 1 probe. This is actually a paper out of my lab, and we looked at basically the augmented Micropulse technique that I just showed you. And again, unfortunately, generation 1 probe because we're still looking at generation 2 probe. But when you look at the Kaplan-Meier curves, we looked at all the patients at Mass Eye and Ear who had gotten the traditional or manufacturer recommended settings versus the patients that got augmented Micropulse. And we found that in terms of survival over time, both for IOP and medication burden, the augmented Micropulse technique did better. And that's why I've kind of stuck with that technique because it works in my hands. And and one of the key things everyone asks, well, what were the complication rates? They were the same when we looked at the eyes, which is again why I've stuck with this technique, because I feel like it works better and I have the same complication rate as if I were using the traditional technique. So some pros and cons of Micropulse. First, I would say it's likely safer than continuous wave TSCPC. The rest of the pros are very similar to the ones I discussed for gprobe, no incision, quick procedure, actually very fast recovery in my experience, even faster than gprobe because the inflammation is much less. Still easy to teach, especially with the generation 2 probe. And I think the one thing I'll say here, lots of settings to choose from, even more than gprobe. And I think that's a pro and a con. It's great because presenting a lot of options here that you can do with Micropulse, but it makes it really hard to do studies and it makes it hard to generalize. So it's again a pro and a con. A con is that or I would say the main con a lot of my colleagues would say about Micropulse is that it's not as effective as gprobe. And In general, I tend to agree, though I say that if you use augmented micropulse, you will get very similar results and still have safety, and be safer, I would say, than gprobe. One big con right now, and I've mentioned this multiple times already, is that no studies have really looked, to my knowledge, at the new probe's efficacy. I think the Iridex has some studies published on their website, but I couldn't find them on PubMed or peer-reviewed articles. And again, I think a lot of us are trying to publish on the Generation 2 probe. And I already talked about the lots of settings to use, and it's still just like you do with TSCPC continuous wave, you can't directly visualize what you're doing. Now, the last technique for transscleral cyclophotocoagulation I'll talk about is augmented micropulse with limited, and I should have included the word limited there, gprobe. And I've found for the sickest of the sickest patients, this works great. And I'm talking about patients who have incredibly high pressures on a lot of medications. I find that using this technique, I get amazing results. And in a nutshell, it's augmented micropulse, which means 90 seconds per hemisphere of sweeping technique, like I discussed, and then 90 seconds of stop and continue technique, like I discussed. But at the end, then I do limited gprobe. And it gets a little tricky because it's up to surgeons, it depends on the patient, and I usually just titrate depending on the patient's situation. But by limited gprobe, and here's us doing the gprobe at the end, I typically, instead of doing 18 to 21 spots that I would do with the regular gprobe, I do anywhere from 3 to 10 spots, sometimes 12. But again, usually my average is 6 spots, 5 spots. And I found that with this combination technique, using augmented micropulse with limited gprobe, I get amazing IOP lowering while still having a very safe procedure in my hands. And we actually published our results in Graphies technically this year, but it was accepted last year. And I'll talk a little bit about this. So again, a drawback of this is that these results were using the Generation 1 Micropulse Probe 2. We're working on updating our results, but so we're using Micropulse and gprobe together. But again, it's limited gprobe as opposed to a full gprobe treatment. Basically, we had, you can see our Kaplan-Meier curves. Our survival rates were amazing. At 1 year, IOP reductions of 30 to 50%. We were having 70 to 80% success without adding medications, which I thought was fantastic. And again, a key take-home point of this article is that the safety was the same, or better actually, than gprobe. I think the main thing we found is that we had a 12% rate of hypotony, but it wasn't even clinically significant hypotony. These patients who were living slightly below 5 did not have clinical signs of hypotony like choroidal effusions or Descemet's folds or anything like that. So I find this technique to be very, very helpful in lowering IOP while also having a safe procedure in your hands, without causing damage. And in fact, none of these patients went NLP. None of these patients were Tricycle. They retained vision. I think there was one patient, I should say, that did turn NLP from a choroidal melanoma, so it was a different, but not from the procedure itself. So I think this is a fantastic procedure, and I think it straddles the, full-on gprobe continuous wave TSCPC with kind of a still very effective procedure, but still very safe. So now I wanted to talk about some patient cases where I've used either Micropulse or a combination of Micropulse with gprobe. This is a sweet patient of mine at the time in 2019. She was 88, white woman, POAG, but also advanced wet AMD, which is why her vision was 21,000 in the right eye. I'm going to focus on the right eye. Was pseudophakic in both eyes, had trabs in both eyes in the early 2000s. The left eye, as you can see, was very functional. Her IOP was 5 off medication, which is great. I think Dr. Pasquale did this trab, amazing job. The right eye, unfortunately, was not functional, had scarred down. And I know some of you might be saying, oh, well, this is her bad eye. Like, why are we worried so much? But, for her, it meant a lot to keep that peripheral vision in that eye. And you can see the size 5 visual field. She has a lot of visual field left. She has those nasal steps, but outside of that, it's still a lot of useful vision. And definitely for her, it was useful vision. So we're trying to save it. Her IOP was actually 14 at the time, but she was on Vyzulta, Alphagan, Cosup, and Repressa, which she understandably was not tolerating. So at the same time, she's 21,000. She didn't want something invasive done. So I decided to do the procedure I just described, which is augmented micropulse with limited gprobe in January 2020. I did augmented micropulse as described, and then 6 discrete spots with the gprobe. And fast forward to my most recent exam with her, which was in January 2022. Well, actually, I'll say first, she's now 91, still receiving IVIs in that eye for AMD. She's 2,800, so she's retained her vision. Her IOP did fluctuate from 3 to 12 until February 2021. And mind you, the procedure was done 2020, so that's some time without medications, actually. Remember, she was on Vyzulta, Repressa, Cosup, Alphagan. So for me, that was a huge success. She did dip down below 5 a few times, but again, it wasn't clinically significant hypotony, no choroidal effusions, no DMFs, deep chamber. She did spike to 20 in March 2021, and I started timolol just once in the morning. And again, my latest exam is really from March 2022, and you can see her OCT looks the same or improved, actually. And her field looks the same or improved, and she's just on timolol in the morning, and her pressure is 9, which is perfect. I always tell patients with severe glaucoma between 5 and 9, that's a holy grail of glaucoma. So very happy patient. And in an 88 to 91-year-old, I avoided an invasive procedure, and then I avoided inflammation, avoided complications. So in my mind, a big success. This is another patient that I wanted to share, and I think I picked this patient for a few reasons. One, it's a good visual acuity patient. I got some questions beforehand. Some people say, oh, do you do CPC in good visual acuity patients? And the answer is yes. I think it just depends on what you're doing. Like this patient, for instance, was a monocular patient, longstanding NLPI in the right eye, but in the left eye, he was 20-25. He was a 50-year-old at the time in 2018, Black man, severe conic angle closure glaucoma, had a retinal detachment in the left eye that was repaired. Then we did phaco with syneculitis. This was actually before I joined Mass Eye and Ear in 2016. Then we did a Burvelt, which again was before I officially joined Mass Eye and Ear in 2017. By the time I saw him in 2018 on brimonidine, Cosup, Vyzulta, Repressa, and Diamox, his pressure was still 21. So we then decided to proceed with augmented micropulse in June 2018. And mind you, his only eye, even though he was 20-25, had a very small central island of vision, basically at OCT at floor. So a very sick eye. But I still did augmented micropulse. And his IOP stayed between 7 and 12 until January 2019, so almost 6 to 7 months on Cosup and brimonidine, which for him was a big lifestyle change. He wasn't taking Diamox, for instance, which is great. He did have a spike to 20. Oh, sorry, I apologize. He did have a spike to 20 in 2021, and I started some medications, but unfortunately the IOP started creeping up. He still kept an IOP of 8 on the same regimen in January 2020, but it got to a point where it still kept creeping up. It went back up to 20, and I eventually did do an intranasal Burvelt, and ultimately he's doing really, really well today, and I'll show you that slide in a second. I first want to say this shows that you can do, especially micropulse CPC in eyes that see well, and in eyes that are very sick also, without risking, snuffing the nerve or anything like that. In general, glaucoma procedures don't last forever, and that's true of CPC as well. So that's something to always keep in mind. And I think this illustrates that too, but they can buy you time. And many times I do see Micropulse, especially as a temporizing measure that can give the patient some time to adjust to, in his case, having a second tooth placed in the eye, which I ultimately did. And the latest update, and this is not CPC related because obviously he has a burr built in, is that he's doing really well. I saw him in April, stable field, stable to improved OCT, vision, still 20/25 in that island. He's actually a saxophone player, still very active, pressure of 7. He is on a lot of medications, but he's not on Diamox, which is good. And we've been able to keep that island of vision going. He ended up having the eye removed in the right eye because the pressure just kept going up to between 30 and 40 and it was NOP, so he removed that. So he's actually a pretty happy camper now, considering everything. So again, and one thing I'll say also about this case is I find many times Micropulse can be a good link between a first tube and a second tube. I mentioned that, and it actually may help you place a Berveld instead of an Ahmed. Sometimes I find that Ahmeds don't work so well long term, but Bervelds do. But Bervelds obviously don't work for 6 weeks usually when you tie them. So this helps you buy a little bit of time, so that when you start seeing the creep up in pressure, then you can put in the Berveld, and many times you get awesome results like this one. Okay, so last poll question of the webinar. Which of the following, and I'm switching to the ECP technique, which is the last part of the webinar, which of the following is false regarding endoscopic cyclophotocoagulation? A, it allows for targeted controlled ablation of the ciliary processes with direct visualization and titration of power. B, it combines a diode, endolaser, aiming beam, light source, and endoscope into a single intraocular probe. C, laser energy administered through the overlying sclera is absorbed by the melanin in the ciliary processes. Or D, combined with phacoemulsification and Cahug dual blade goniotomy, it creates what's been named as the PEC procedure. So I think we did a great job here, actually even better than the other ones. So the ones that's false is that we're not administering it through the sclera. That's the point of ECP. All the other ones are actually true. Great. So endoscopic cyclophotocoagulation, or ECP, it was initially developed in 1992 by Martin Uran. Again, the probe does combine the endolaser and a light source in an endoscope. And it minimizes some of the disadvantages of the more traditional cyclodestructive procedures that we just talked about, because you're directly visualizing the ciliary processes. So you can titrate power as you go, which is one of the main benefits of this. And this is a video I made here at Mass Anir. I'm actually going to narrate it myself instead of letting you listen to me, because we just couldn't hear it very well, and I apologize for that. But this is me in our OR. The first thing is that I'm picking up the probe. It's a sterile probe. We were about to do a case. I was trying not to contaminate anything. And I'm just showing you that I'm using the curved probe. And I find that when I'm doing anterior segment procedures, using the curved probe is a way to go more than the straight probe, which are more used for pars plana procedures. Some of my retina colleagues sometimes do pars plana procedures with the curved probe. Now we're looking here at the machine. The first thing I do is start with the laser power. I usually start at 0.35 watts, but you can go all the way up to 0.5, and that's what I'm showing there. You basically want to titrate it until you see whitening and shrinking of the ciliary processes. Then the laser duration, I always use continuous. So again, the ECP, it is a continuous laser. Then in the center, I enable it. I like the aiming beam to be 40. I find that way, especially when you're working with trainees, you see a clear red dot, you know where you are, and it's not as confusing. And then the count at the end just tells you the count of the laser. I don't find the count means much, honestly, but the nurses always like to write it down. So I guess it's a way for people to keep track of everything. And then I'll show you the machine one more time. And one thing I didn't talk about in the video was the illumination, which basically you want to titrate until you can still see that red dot in the center. And I'll show you some videos of ECP in a second, but you can still see that red dot, but also see some of the ciliary processes that you're treating. Usually you want to see between 4 to 6 in view. And this is a video of the ECP. Sorry, let me just, you can see that. And this is essentially, I've already done half of it. You can see all these processes are whitened and shrunken. And now I'm trying to do the other half of the eye. And you see, I'm trying to have whitening and shrinking of the processes. And I usually paint. Once you get good at this, you can just go through and paint. Ideally, you want to try to get 270 degrees of processes, but you can imagine it's hard to do for novices or people who don't have a lot of intraocular surgery experience. And it's also hard to do with one incision, which I always try to avoid doing a second incision. But here, I basically tried to do 2 coats of laser. So that's why I had already painted the superior portion of the eye. I was painting back over it, and I do the same thing inferiorly, paint back, and then end in the center. And this is one of my trainees doing it, one of our wonderful residents. So it's a little shakier. And, you know, trainees, when they start, they try to go one by one. Here, the trainee is getting a little too close. There was a little explosion of the ciliary process. I will say one of the key things I've learned over the years is to really control inflammation when you're doing ECP. I feel like that really lends a lot of success to the procedure, because if you do have those micro explosions, which ideally shouldn't have, but it's not the end of the world if you control the inflammation. And again, a little bit of a trembling there because I'm trying to walk the resident through it, but ultimately we get it done, and the patient does well, and the resident gets to learn how to do the technique, which is great. And again, we're just trying to see whitening and shrinking of the ciliary processes. I think for residents, it's really hard to get to the 270 degrees. One thing I'll mention later, in terms of lessons learned, is try to use a very thick viscoelastic, Helon GV, Helon 5. That'll keep, especially with trainees, because that'll keep the sulcus nice and open for you, so you don't have to worry about lasering the iris root or the pupil. Or the zonules, right? You're just going to have a nice open space where you can just focus on your ciliary processes. I already talked about controlling the inflammation. Many times I do give solumedrol intra-op for these patients because I do a lot of PEC and ICE2 procedures, which I'll talk about in a second. It's a lot of surgery for the eye, but again, if you hit them hard and control the inflammation, these patients do well. And again, this is the end of the ECP by the trainee, and she did a great job. The other thing I'll say is I make my incisions straight temporal many times, which can be challenging for, again, novice trainees when they're trying to do phaco, because I do a lot of combination procedures. So if you're trying to do phaco with a straight temporal incision, that can be a little bit challenging at first, but I find that that's the best way to put the incision so you can actually reach those 270 degrees that I think are ideal if you can with ECP. And again, this is out of our review article that I presented at the very beginning of the webinar, but this is looking at ECP, and it basically looked at all the studies between 2007 and 2018 that we could find. And again, the IOP reductions can be dramatic. You know, ECP is one of these procedures that sometimes people poo-poo it, but you can actually get a lot of IOP lowering depending on the patient you do it on. I find that angle closure patients do particularly well. And there was actually a paper out of Mass Annual by Mike Lynn, one of my colleagues, that showed that in fact, chronic angle closure patients or angle closure patients do particularly well with ECP. The reduction, again, 6 to 70%. And the medication burden is actually pretty good in some patients. And you can decrease medications by up to 3.2 depending on what patient you choose. I want to put in a plug for what I call the PEC procedure. My lab published an article in 2021, 2020, looking at the outcomes at 1 year of the phaco, ECP, KDB, and I'll show you a video in a second, versus iStent cataract surgery and ECP. The main drawback of this article is that at this time we had only used the generation 1 iStent. But at least the PEC results still stand. And at the 1 year mark, we saw IOP reduction up to 5 millimeters of mercury and medication reductions of almost 2, 1.6, 1.7, 1.8, which is great. The one caveat I'll say is that these were mostly mild to moderate glaucoma patients, especially in the ICE1 group. There's some moderate to severe patients in the PEC group, and I sometimes get good results in those patients, but I tend to focus on the mild to moderate patients for combination MIGS. And this is a video of the PEC procedure. Usually I do the cataract surgery first. One of the main reasons I do the cataract surgery first is I work with a lot of trainees, and I like to make sure the cataract surgery went really well before I do anything else. You could do the angle procedure first. And in fact, a lot of surgeons in the US do like to do the eye stent or the cahook first because they have a better view, right? The cornea is not compromised. But usually I do the phaco first, and I do the ACP. You saw me do the ACP. I try to do as much ACP as I can. Usually it ends up being that I don't get to 270, and it's more like 200, 220, 250. And then at the end, I do the cahook blade. I like to do the inside out technique. And I leave 2 leaflets of the trabecular meshwork hanging. I always use myocl at the end of the case. I find that that helps with my dry SS. I think that was one of the questions beforehand. And again, I hit them really hard with steroids, assuming they don't have any comorbidities like diabetes, because I find that if you control the inflammation well, these 3 surgeries do really well, right? You don't have to worry so much about fibrin or inflammation or decreased vision for a long time with the patient. This is the ICE2 procedure, and we don't have any publications yet on this procedure. We're actually working on them right now. We also switched to generation 2 iStent, which has 2 iStents instead of 1. So I think it'll be curious to see how this compares to the PEC. The PEC seemed to trend a little bit better than the ICE1 procedure, even though the Kaplan-Meier curves weren't very significant. But we're really curious to see what the ICE2 procedure, how it stands to the PEC. And here again, I do the phaco first, I do the ECP second, and then at the end, I do the iStent. But again, you could do the iStent first when you have the best view. And here we're placing the 2 iStents a couple clock hours apart. And again, we're working on data for this, although I'm afraid that by the time we publish this data, the iStent Infinite will be out, and then we'll have to focus on that. But anyway, that's the world of glaucoma for you. Changes a lot. So now we're towards the end of the webinar. I just want to share some successes and challenges that I've faced with ECP procedures, phaco ECP procedures. So I want to present the case of the 70-year-old white woman. She presented to my clinic with already NLP vision in the left eye from an acute angle closure attack that was not treated promptly. So we were worried about the right eye. She was 20/20, but had an IOP of 21 on latanoprost, some thinning on the OCT, 82. I tend to think that an OCT below 100 is not perfect, is not normal. Some borderline thinning superiorly, maybe some scattered non-specific defects in the visual field, but I mean, not an unhealthy eye. Narrow angle, it had not been treated yet. She had not had an LPI. So I suspect the plateau iris on gonioscopy because I did feel like I saw the double hump sign, and she did report some difficulty driving at night. So I proceeded with phaco ECP in February 2019. And the happy update is that in 2021, she was now 72, had a completely open angle. Her pressure was 10 on the latanoprost, and her fields and OCTs were stable to improved, and obviously no difficulty driving at night because the cataract was no longer there. So a very happy result in a monocular patient that I chose to do phaco ECP instead of doing an LPI and just watching the cataract. This is another happy result, but it started also with an acute angle closure attack in April 2021, 66-year-old white woman. Angle closure attack in the left eye, narrow angle in the right eye. She did undergo iridotomy. She came overnight. I think the glaucoma fellow did the LPIs in both eyes. She presented to my clinic on follow-up and had an IOP of 13 at the end of April with COSOPT in the left eye, difficulty driving at night, and also developing an allergy to COSOPT. So I also decided to proceed with a phaco ECP procedure in the left eye. In the right eye, I only did cataract surgery. And again, this is another very happy camper in July 2021. Her acuities corrected were 20/20, 20/25. Amazing pressures between 8 and 9, off medication in both eyes. Very, very happy camper. And I honestly saw her yesterday in clinic, and she was still doing wonderfully, but I couldn't update the slide. Now, not everything is perfect in glaucoma, as we know, so I wanted to share some challenging cases that I've seen. This is the case of a 56-year-old Hispanic man who presented with narrow angle glaucoma, or chronic angle closure glaucoma, had LPIs in both eyes. The left eye, you can see very sick eye, island of vision, severe stage glaucoma, although again, very good vision in that island of vision. The IOP not well controlled despite 4 medications, did have difficulty driving at night. So I did phaco ECP in May 2018. The IOP initially lowered to 12, and I kept adding medications on board from 2019 to 2020. I did have to do a capsulotomy, and I find that, we're studying that too. I find that PCOs do develop a little bit more when you do ECP. I added another medication because you really didn't want more surgery, but the visual field worsened, and then I did do a Burvelt ultimately in August 2021, and he's doing really well now. But again, it's the phaco ECP didn't do too much for him necessarily. I had to keep adding all the medications. I had to do the capsulotomy, and ultimately he did need a Burvelt. This is another case, 61-year-old Black man, open-angle glaucoma, moderate to severe, difficulty driving at night. The visual field had worsened despite 5 medications and 6 failed surgeries. And actually they were all done by me, I have to admit. It was a very challenging case. I tried a Zengel that encapsulated, an Augmented that encapsulated and caused diplopia, Augmented Micropulse ×2. I put in a Burvelt inferior nasally, and ultimately had good IOP with less medication, but developed a cataract that he was bothered by. So I did phaco ECP in July 2021. And despite the fact that his pressure is amazing, it's 11, it's exactly where it needs to be, he developed CME. And this is despite the fact that I treated him very aggressively with anti-inflammatory medication. So sometimes, unfortunately, this is something that you have to watch out for with ECP, that you get CME. I think the latest, I saw him recently a couple of weeks ago, and I'm sorry I couldn't update the slide, but he's doing better now. I think he got some injections with retina for the CME, and the CME finally went away, and he's doing well, and his pressure is fantastic. Anyway, something obviously frustrating for the patient and for the surgeon, so something to watch out for. So we're at the final stretch here, and then I'll open up for questions. I can stay after 10 and talk a little bit more. But I found that in general, controlling inflammation early and aggressively is very important in all cyclodestructive procedures. I would be extremely careful in uveitic patients, although I do Micropulse and sometimes ECP in uveitic patients. But again, the inflammation has to be very aggressively controlled. Sometimes even using triessence in the anterior chamber is important. And I found also with Hispanic and Black patients, you do have to be also careful with inflammation. I find that ECP is best for mild to moderate stages of glaucoma. I tend to avoid in severe stages because they end up needing something more. No such restrictions for CPC, especially with Micropulse. I feel like it's particularly safe, even with the augmented settings that I showed. I find that angle closure patients in general tend to respond very well to cyclodestructive procedures. Combination MIGS, CMIGS, I'm a big fan of this. I gave a talk recently at Bascom about this. I'm studying this very aggressively. I find that you can harness the benefits of individual MIGS when you combine them, and patients do really well, especially when you're trying to decrease medication while lowering IOP at the same time. I already mentioned that, when you're doing ECP, try to treat 270 degrees if you can. Use the curved probe in the AC. I think it's easier. Try to use a very thick viscoelastic to open the sulcus, especially when you're teaching trainees. And I think one of the key things is tempering patient expectations. For all cyclodestructive procedures, but especially glaucoma surgery in general, I really like to remind my patients, no surgery lasts forever. Even the best trabs usually don't last forever. It's really, we get lucky when you have a surgery or procedure that lasts forever. And I think I found that if you are open with patients from the beginning, you say, listen, we have to treat the pressure because the drops are giving you an allergy, or the pressure is too high and you're going to go blind from glaucoma. I don't know how long this is going to last. Studies show it may last this long. We'll take it one step at a time and go from there. I feel like patients respond well when something doesn't go perfectly. I want to thank all of you for listening to this hour long, and I apologize, I went a little bit over. I was supposed to talk for 45 minutes and then open it up for questions, but I'll stay behind and answer questions. I want to particularly thank my research assistant, Hennis, my current research assistant, Hennis, who put a lot of work into editing the videos and putting the slides together. Thank you, Hennis. And if there are any questions, I'll try to answer them now. And this is my email also, if anyone wants to reach out to me and answer, ask me any questions specifically. It was a pleasure to give the webinar today. I hope it was helpful. Is there any direct scleral side effect of TSCPC? Is it a painful? So is there any direct scleral side effect of TSCPC? I find that there isn't. Some of my colleagues with the gprobe have had some complications of scleral burns. There was even a perforation once with the gprobe, which is again why I'm not like the biggest fan of just using gprobe. Micropulse is definitely very safe. I think the key thing I've found is using a very thick, coat. Like if you use OcuCoat, a lot of OcuCoat, and you protect the surface of the eye, patients do really well. So I find that in general, the answer is no. But I think you just have to be very generous with the OcuCoat. Is it a painful procedure? I'm very fortunate to work at Mass Eye, where we have a great anesthesia department, and I block our patients. When they can't perform a block, I many times do a subtenos block myself, which honestly is actually fairly easy. I just make a small incision infranasally and use a cannula and give the block. But I find that you have to block the patient. I know some of my colleagues in Chicago, some people I know, they say, oh, I don't block, I just use tetracaine. That's not been my experience. I do think that without a block, it is a painful procedure. And you won't be able to do, for instance, the augmented settings or combine it with limited gprobe if you don't block the patient. Do you suggest different technique or setting in the case of long or short eyes? I really don't. I really haven't found that the axial length has any effect on CPC outside of, I do find that, as I said at the end, that angle closure patients who, tend to have shorter eyes, obviously do a little bit better, but I use the same technique, and I still get good results with all sorts of eyes. How can you set the number of continuous wave CPC shots, augmenting and micropulse? So I think what you're trying to say here is how many shots of gprobe do I add to the augmented micropulse? And that's a great question. And, it depends on the pressure when you're going to the operating room, like before, when you book the surgery, and what the aims of the surgery are, right? So if I start with a pressure of 30 and they're on 6 medications and I'm trying to lower the medication burden and lower the IOP at the same time, then I tend to do maybe more like 8-10 shots of gprobe. In general, I think my average is around 6. I've done as few as 3 though, so sometimes I just feel like they just need a little extra help. So unfortunately, I don't have a good rubric, a good table to tell you, oh, and this patient do these number of shots, and it's one of the limitations of the procedure. But I basically go all the way up to 12 in like very, very sick eyes. And then I try to stay around 6, I would say, for most patients. And then patients who need a little less, I do 3. Hopefully, I hope that was somewhat helpful. Can we do this in the baby or older children? What is the setting? I don't do a lot of pediatric glaucoma, full disclosure. I have done this in young patients. I remember a 12-year-old from Cape Verde. I did augmented micropulse in, and a 20-year-old, I guess he's not a child anymore, he's a young adult, but a juvenile open-angle glaucoma patient, I did augmented micropulse, and they did really well. I have not done gprobe in younger patients, and I try to avoid it. I feel like that's a very definitive procedure for a young person, but I think micropulse is safe to do. I had good results with the young patient I did and with that 20-year-old, and it was safe. And I think micropulse is a very safe procedure. I think the main risk is that it won't work. So how long is the expected effect of TSCPC? It's a great question. I think it depends a lot on the settings, how long it's going to last. I tend to think that you can get good results up to 3 years. I mean, I just presented some results of patients who had results 3 years out, and they're doing well. In general, I do tend to think that especially micropulse and even augmented micropulse with gprobe, it does wane over time, the effect. So it's not a forever thing. And I do think you need to temper patient expectations. The good thing is, though, you can repeat it. And I have repeated CPC with good results, and I get another 2-3 years out of it. So anyway, but I think a lot of studies show that it can last 2 to 3 years with good effect. So could you expect a titratable effect of TSCPC on IOP? Yeah, absolutely, especially when you're trying to do that augmented micropulse with gprobe. Obviously, the more spots you do with gprobe, the more IOP lowering you're going to get. So I guess from that standpoint, you can titrate the effect. I mean, my augmented micropulse technique, I just use the same for everyone, essentially. So I don't feel like there's a lot of titrating. You could titrate the power, but I've actually now, with the generation 2 micropulse probe, I've stuck to 2.7 watts with really good success. So I don't necessarily titrate that anymore. I just start with 2700 or 2.7 watts, 2700 milliwatts or 2.7 watts, and I have good success. How do you predict the effect of combined procedures on IOP? That's a great question. The study that we published for the PEC procedure, it really seemed that it was additive, the effect, like the effect that you get from ECP and Cahook, and even a little bit from the cataract surgery does kind of seem to add up. I will say, CMIGS is very controversial. There's not a lot of data out there. We actually are publishing a review article on the few papers that have been published on CMIGS, but definitely more research has to be done. And we're actually in the process of doing that in our lab too, looking at all the CMIGS procedures that have been done at Mass Eye here, comparing them to the SMIGS, what we're calling SMIGS, which is just phaco with 1 MIGS procedure. So I think the jury's out. Anecdotally, and based on that one paper, I do tend to think there's some additive effect, but the more work needs to be done to show that. Yeah, how much IV Sola-Del do you give after combined procedures? I actually hit them hard. I give 1 gram, which is a lot, but my patients do well. And I would just say, just be careful with your diabetic patients. With those patients, I tend to maybe give 500 or just skip it and just hit them hard with topical steroids. I do also do a Medrol dose pack for 6 days when I do combined procedures with ECP. So just keep that in mind too. But again, just be careful with diabetic patients. Outside of that, I really haven't had a lot of issues, and the results in the eye have been wonderful because the inflammation goes away very quickly and the acuity recovers quickly, which is great. How much risk of developing a cataract does ECP have? So I don't do ECP in phakic patients. I don't know if you meant to say CPC. I have done CPC in phakic patients, and I do think it speeds up the cataract formation. I think any procedure you do to an eye will speed up the cataract formation. But I don't know. I'll do cataract surgery when it comes to it. It doesn't faze me too much. ECP, I always do it in pseudophakic patients, so they've had their cataracts removed. I do think that it increases your chances of getting a PCO if they haven't had a yet capsulotomy. Again, we're working on actually showing that, because anecdotally, that's what I've noticed in my clinic, that when I do ECP, my patients have a higher risk of getting a PCO. But again, I think if you counsel the patient and they do well after yet capsulotomy, it's fine. What is your preferred anti-inflammatory regimen? We talked already a little bit about that. For combined procedures, I do the IV Sola-Del, the Medrol dose pack, and then I do Predfort or prednisolone acetate, 1%. For CPC, and I should have mentioned this during the webinar, I sometimes can get away with less, and I actually sometimes try to. Augmented Micropulse, for instance, is not very inflammatory. Sometimes the anterior chamber is deep and quiet, or deep with rare cell the next day, and I can get away with Lotemax. I've gotten away with Ketorolac in some patients who have a strong history of steroid response, and I feel like that's great. Those patients do really well. Obviously, if you do see more than 1+L or 2+L, I do start at least prednisolone, and obviously when I see fibrin, I sometimes switch to Durezol depending on the patient. A wonderful presentation. Thanks. Thank you. What is the power used in your augmented Micropulse settings? Any maximum times you repeat Micropulse before considering other surgeries? That's a great question. Augmented Micropulse, again, I do 90 seconds per hemisphere of the sweeping technique, and then I do 90 seconds of the stop and continue technique. So I end up doing 180 seconds per hemisphere, which ultimately it's 360 seconds total. So that's my augmented Micropulse setting. And again, there's 2 publications out there. The Gray Feast publication is the more easy one to find, and it's described in there if you want to actually be able to justify what you're doing with some evidence-based medicine. In terms of maximum times you repeat Micropulse before considering other surgeries, it's a great question. It really depends on the patient and the situation. I typically will give Micropulse 1 shot before moving to a tube, because most of these patients have already had failed traps, et cetera. And then try Micropulse again if the second tube fails or the first tube fails. But Micropulse can be repeated, and I've done it as many as 3 times. I do think you lose some effectiveness, and it kind of makes sense, right? That you lose some effectiveness over time. But usually I try it one time, then jump to a tube, and then after that, try it again if the tube fails. Do you transilluminate the ciliary body in Micropulse? I don't. I just don't find that the transillumination helps me very much. So I just, the bunny ears are against the limbus, and I'm very careful. And I think if you do it how I showed in the videos here, you're going to be okay. Thank you. You're very welcome, Mortessa. And then, do you use homoatropine post-op? I typically don't. Micropulse, definitely not. I don't think Micropulse ever needs atropine, really. Sometimes with the augmented Micropulse and gprobe, if they're a little hypotenuse, or if they're having a little bit of pain and I'm trying to stay away from heavy-duty steroids, I'll use atropine. But it's rare, honestly. With these settings, I don't have to use atropine very much. I think patients do really well. And actually, my dryasses, which was a question I got in advance, it's rare. As long as you avoid the 3 and 9 o'clock positions, using Micropulse and using Micropulse with limited gprobe, it's rare to get my dryasses. When you repeat Micropulse, how many days? Well, so usually, if I have a failed Micropulse patient, I won't necessarily go straight to another Micropulse. I will actually do a tube or Zen or do something else for that patient. When I repeat it, it's usually years later, either because it's lost effectiveness after years. Like I want to see, and this is actually a rule I use for most of my glaucoma procedures. If I'm going to repeat a procedure, I want to see that it worked. So if I did Micropulse and in a month it's not working, then you have to switch gears or change your settings or do something different. So if you're going to repeat it, at the very least, I would crank up the settings and go even higher than whatever settings you used. But usually I won't repeat it so quickly. So usually it's like years or after a failed second procedure that I'll repeat the Micropulse. Okay, perfect. Well, thank you, everyone. Thank you for the opportunity, and have a good day, everyone. Take care. Bye.